Without much further ado, though, I would like to, first of all, extend a very warm welcome to our distinguished guests, extended alumni from the region, colleagues, and friends. This is our second edition of the Public Health Thought Leadership Dialogue for 2016 and is presented to you by the Salisbury Hock School of Public Health. Today's topic is on capturing the value of prevention. Now, those of you working in clinical practice or in health in general will remember that an ounce of prevention is actually worth a pound of cure. Now, truth be told, that does not translate past these four walls because we all live in this world where hospitals need to guard their bottom line. But before I wax lyrical on the subject, I would like to invite the Dean of the Salisbury Hock School of Public Health, Professor Chia Ki-seng, onto stage and take over, and perhaps say a few words to introduce our special speaker for today's session. Professor Chia, please.
Well, thank you very much for joining us today at the Public Health Thought Leadership Dialogue. This dialogue series, we aim at addressing complex public health problems and global health problems that we are facing today. And this series of dialogues that we've been organizing is organized under a setup within the school, which we call the Leadership Institute for Global Health Transformation, or LIGHT for short. We hope that to expand the output of this dialogue series into the formation of think tanks, production of white papers, as well as leadership training programs. In fact, we just recently had a leadership training program held in Manila on leadership and change management, and thanks to our alumni from Manila help us to organize it together with the Department of Health of Philippines. So we have also Vivian and Ivy from our alumni from Manila joining us today. We also have Khalifa, one of our alumni, who is the Director General for Public Health in the Department of Health Brunei. At the same time, we have my good friend also from Malaysia, Professor Rahman Jamal, who is the PI of the Malaysian cohort of 100,000 Malaysian cohort. And also from Thailand, Dr. Kuman Uchusat, Special Advisor in the Department of Disease Control in the Ministry of Public Health in Thailand. So we're very thankful that we have several of these foreign guests with us. Unfortunately, two of our alumni from Vietnam and from Bhutan, they were unable to join us at the last minute because they couldn't get their travel documents in time. This afternoon's Public Health Thought Leadership Dialogue is on the theme capturing the value of prevention. If you have followed Singapore's government's recent budget debate by the Ministry of Health, you'll find that there's been a very refreshing kind of shift of focus. You can't deny that the shift was from just merely on healthcare to greater emphasis on health. And you have heard about the declaration of the war on diabetes by the Ministry of Health. And one very strong underpinning of this war on diabetes is on the prevention of diabetes. So we're going to be faced with several questions in the time ahead. Is prevention really more cost-effective than cure? How do you actually measure the impact of prevention? How do you measure the impact of something that didn't happen? I can measure the impact of treatment of a stroke patient, treatment of diabetic patient, but how can you measure the impact of something that did not happen? And how do you position the importance of primary prevention in this day and age of personalized medicine? So these are some of the issues I think that we need to be confronting ourselves with. And to help us today, we have Professor John Ioannidis, to kickstart this process. John is the director of the Stanford Prevention Research Center and co-directs the Meta Research Innovations Center at Stanford. He grew up in Athens, Greece, fell in love with mathematics at a very young age, and at the age of 19, he was awarded the National Award of the Greek Mathematical Society. 6 years later, he became a doctor. He is indeed a rare breed, a doctor who loves mathematics. Not only that, he's also a writer. He writes novels. So you really have a very rare specimen of an academic in the audience today. I met John 10 years ago and at a symposium on cohort studies in Stockholm at the Karolinska Institute. And the way he was looking at how cohort studies should be developed was indeed absolutely amazing. I mean, it blew my mind. He spent a great time of his research in meta-analysis, quantifying bias, error, and outright fraud in research. And if you look at the internet, you'll find that the first hit that you get is his 2005 PLOS Medicine paper, Why Most Published Research Findings Are False. And I just checked this morning, the paper has 1.6 million hits and over 7,000 citations if you combine all the different sources together. So it's one of the most cited paper and one of the most viewed paper. And not surprisingly, some people referred him as an uncompromising, gentle maniac. And another mentioned that he's one of the most influential scientists alive. So indeed, I think this afternoon we are in for a treat, and we look forward to John sharing with us on capturing the value of prevention. John?
Thank you for this very warm introduction. It's a great pleasure to be back in Singapore after a number of years. It's always a very beautiful and exciting city, but I see that it's becoming even more beautiful and more exciting. And for the National University, I've always known that it's a great university, but each time I see that it's becoming even greater with new facilities and great people working on very interesting questions. So I was asked to tell you how to capture the value of prevention, and do I know how to capture the value of prevention? I'm not so sure about it. I have some thoughts. I have a little bit of evidence that has been accumulated and some ideas. I think we know a few things, but I also look forward to discussing that topic and see whether we have some new ways to capture the value of prevention. So, prevention is the best idea medicine ever had. I'm the chair of disease prevention. There's a little bit of a conflict of interest in saying that. And it can really be a cornerstone in reducing the burden of disease globally and in enhancing wellness and overall well-being of individuals and of communities. More than 50 years ago, it was stated that clinical epidemiology also is the basic science of prevention. So lots of the interface of medicine with mathematics and quantitation and measuring really started from prevention. Because back then, before World War II, we didn't really have many treatments. We were lucky, in a way, that we could focus more on prevention. But then therapeutic medicine became pretty successful. We had lots of treatments, and prevention kind of slided aside. Now, I have to say that not everything preventive works. In fact, some approaches seem to be pretty low yield, even though we have a long tradition and a long history of trying to implement them. So one big theme in prevention is screening, and you have seen that resurrected multiple times. Probably the latest resurrection is in the realm of precision health and the ability to measure zillions of things on people who are perfectly happy and perfectly healthy, but they want to become very anxious about what will happen to them. So after a century of research and screening, when we did a meta epidemiologic assessment of randomized trials and their meta-analysis, we found only 4 screening processes that have shown strong evidence in reducing cause-specific mortality in randomized trials, and almost no screening process that shows an equivocal reduction in all-cause mortality, although I'm sure that they do, but to capture a reduction in all-cause mortality in the long term, you really need tremendously large studies to be able to document it. This doesn't mean that screening doesn't work. There's many other reasons to perform screening, many other conditions or diseases that you can try to detect and do something about, but it hasn't necessarily delivered that complete paradigm shift that we have all wanted in terms of annihilating disease early on. So how do we capture the value of prevention? There's probably 5 major ways to do that. One is anecdote. It could be personalized anecdote. This is something that I did and that worked for me. I don't think that that should be discarded, because people are different and they may want to have different narratives about what is important in their lives and what makes sense for them. And if you have strong evidence from the best randomized trials, but nevertheless they feel that something else has worked for them, you need to consider that seriously. There's observational evidence, uncontrolled and controlled, but not experimental. Uncontrolled is something that we do very often. So we run programs and we capture how many people did hear about do something about your diet or exercise more. We can record that I informed so many million people that they need to do something about their diet. Well, did they do something about their diet? Did that affect their outcomes? Did they live longer and better lives? We don't really know, but at least we can record that the message got out. We have randomized evidence. We have hybrid designs that we can combine some of these designs together. And finally, meta-analysis to look at the universe of evidence or lack of evidence in some cases. So observational evidence has been pretty predominant in most of public health for a large period of time. But unfortunately, it's often fragmented and of questionable reliability. So I will show you one example from a paper that I published with John Schoenfeld from Harvard 3 years ago in the American Journal of Clinical Nutrition. We did what I call a cookbook systematic review. And it's literally a cookbook review, because we did open the Boston Cookbook, which has been out there since the 19th century. We used a computer to generate random numbers and randomly selected 50 ingredients from the recipes within the cookbook. And then we went to the scientific literature to see how many of those are associated with significantly increased or significantly decreased cancer risk in the scientific literature. And therefore, that would be one hint that, don't eat a lot of that or eat more of this if you want to avoid cancer. This is the ones that were associated with cancer risk. It looks like a poem that I could have included in some of my experimental writing. Veal, salt, pepper, spice, flour, egg, bread, pork, butter, tomato, lemon, there's 10 out of the 50 that are missing from that list. So 40 out of the 50 are related to cancer, but actually these 10, we didn't really search very well. So we searched for the name of the ingredient. We didn't search for the biochemical component. So vanilla is not there in that list, but vanillin has been associated with, I don't remember, is it increased cancer risk or decreased cancer risk, or maybe both? I think that if we were to look at the ingredients, then everything probably has been associated with cancer risk. And this is how it looks like. These are relative risks for different types of cancer in the 10 most recent studies for each one of the cancer locations and for each one of the ingredients that we studied. And you see that for most of them, there's action on both sides, so both good and bad. Wine is good and wine is bad. Tomatoes are good and tomatoes are bad. Tea is good and tea is bad. Well, sugar is mostly bad. And salt seems to be always bad. But how many of these relative risks really are reflecting reality? So I do believe that some of these ingredients do increase or decrease cancer risk. So I think that sugar probably has some effect, and I think that meat might have some effect, and fruits and vegetables are great, and I recommend you to have more. But for example, fruits and vegetables, what might be a reasonable risk ratio for one more serving per day? We have some very large studies like EPIC that suggest that for one serving per day in fruits or vegetables, you decrease the cancer risk by about 1 in 1,000. So relative hazard of 0.999. If you're lucky, 0.998, 2 in 1,000. So how would that show in that plot? It would really be indistinguishable from 1. I mean, it would scratch the border of that line, barely. So even for the ingredients that seem to have an effect, the estimates of relative risk that are plotted here per serving, more or less, are really unrealistic. I mean, there's no way that sugar, no matter how bad it is, will increase cancer risk 3-fold per serving, or that beef will increase cancer risk 5-fold. Absolutely no way that that would happen. So how do we go about measuring relative risks that are pretty small when we're dealing with single factors, single ingredients, but which cumulatively may really accumulate a substantial impact on the burden of disease like cancer, and even more so cardiovascular disease or other conditions? One option is to perform meta-analysis and try to put all of these studies together. And this is what happens with meta-analysis. This is pretty much the same data. And these are z-scores from the normal distribution, that old Gauss guy. If you get a -2 or less or a +2 or more, that's a nominally statistically significant result. It's less than p less than 0.05. So the green color is the p-values that are prominently reported in the abstracts of these papers. And you see that if you collect single studies, all of them show significant results. There's very, very little action in the middle. Even those that have some non-significant results, they have some other significant results in the same abstract so that they can cover their back. We recently looked at the entire biomedical literature with text mining, and whenever there's a p-value in an abstract, 96% of the time these papers suggest significant results. If you look at the full text, again, 96, 97% have significant results. Now, you can look a little bit more deeply into the fine print and get some additional primary outcomes that are not prominently reported in the abstract. And then you get these grayscale p-values that many of them are in the middle, but still there's a huge gap between the two extremes of significance. And given the tiny size of these individual ingredient risks, it's most likely that these studies, which are typically studies of a few hundred up to a few thousand people in case and controls, would not have been powered to detect these tiny risks. So we're missing a huge component in the middle. Now, if you perform the meta-analysis, some of that middle ground, the non-significant results starts filling up, but it doesn't fill up entirely. And the reason that it doesn't fill up is not so much that there are some ingredients that have some effects on health outcomes and mortality or whatever, or cancer, but mostly because there's huge selective reporting in the literature. We love significant results and we want to disseminate significant results. There are a number of empirical evaluations that have looked at the most highly cited observational designs, and unfortunately the track record is not good. They have been done by the best scientists under the best circumstances with, it's not that I can say that if I were to do those, I would have done better, but 5 out of the 6 most cited claims of observational studies were refuted within a decade of being published. And actually, Stan Young, about 5 years ago, took a more in-depth look, and he found that 52 out of 52 major epidemiological claims were not validated when tested in randomized trials. I think he's a little extreme, but not that much, perhaps. So even when we do detect something that is real, it's likely that it will have less of an effect compared to what the real effect, so what we detect will be stronger compared to what the real effect is, because of multiple reasons that are related to the winner's curse phenomenon. So there's a poor replication record for observational claims and also for claims with a long translational life cycle. This is an evaluation of the most highly cited papers that have been published in clinical medicine looking at different interventions. And I have classified separately those that were quote-unquote refuted, so we did much larger, better controlled studies and we couldn't see really that effect, versus those that were not refuted, or sometimes, actually we never tried to replicate some of those, but whenever we did see something that was equally strong. And you can see that it takes a very long time from the first time you have a theory until you develop some clinical evidence that you have something to affect that would change outcomes. And usually the claims that are refuted are the ones that have lingered for a lengthier time. So things like hormones, take hormones all women should take hormones after menopause, big claim for a long time, then WHI completely kills that. Or many of the dietary interventions, claims being made for a long time. Claims that have lingered for a long time are more likely to be refuted. And the reason for that might be that these claims might have been tested by many investigators over many years, and perhaps some of the best results, some of the most promising results came forth and made a big story about these being the solution and the holy grail of prevention or of treatment, but actually that not being the case. So if we want to study the environment and our life and what surrounds us, it's better to do it not taking snapshots of single things, but trying to look at the entire exposure to many different things that happen to us. So along with Ki Seng, we published that paper in 2009 where we introduced the concept of correlation globes for exposure-wide assessment. So I asked him, instead of looking at a single association in the Singapore cohort, to analyze all the variables that he had in his database against all other variables. So at that time, I think there were about 2,000 variables. So this is just a snapshot of that correlation globe looking at just 19 of them. And these are dietary intakes for things like fruits and vitamin A and vitamin C and cholesterol and iron and meat and so forth. If you see a link, it means that these exposures are correlated. And if you see a thick link, it means that they're strongly correlated. Practically everything is correlated with everything. So if you intervene at the level of a single exposure, like try to change intake of rice, it's impossible that you will just change rice. You will perturb the whole globe, because people will do other things if they reduce their rice uptake. They will do something else to kind of catch up with what's going on with them. And this is just looking at a snapshot of nutrition. There's many other exposures that surround us and that we would want to tackle effectively somehow. So here's another exposure-wide assessment looking at determinants or correlates of lipid levels in the National Household Survey in the US and Haynes. And what I'm focusing on here is environmental exposures, toxins, pollutants, pesticides, and so forth. This looks like a genetics Manhattan plot, but actually we just stole the idea from the genetics Manhattan plots. It's a Manhattan plots for environmental determinants, but it's pretty much the same concept. We have 4 waves of data, so we can validate these associations, these correlations across different waves of information, and identify some that have consistent patterns of again and again showing some impact on lipid levels, as in the slide that I'm showing you here. And this is the equivalent correlation globe for triglyceride levels. I have selected just the potential risk factors that showed the strongest repeatedly seen results. And again, you see a pretty dense correlation globe. So it could be that all of them might affect triglyceride levels, or it could be that some of them affect triglyceride levels and the others are just mirroring these effects. Increasingly, we have more and more data to play with. And many countries have started developing nationwide population databases that increasingly collect more and more information and may also be linked to biobanks. Less than a year ago, along with Ann Singh, who recently joined our team at Stanford, I wrote that piece to discuss an example of such a nationwide population effort in Taiwan. But there's several others that are happening, and this is just comparing 3 such efforts in Taiwan, in Sweden, and in Korea. The Sweden one is the oldest one, and Singapore has also been very active in developing epidemiological cohorts and collecting population information. This is really great because we can track lots of things at the population level, we can perform lots of analysis, we can perform lots of observational epidemiology, but at the same time, the benefit of having access to all these data also multiplies the dangers of all the false positives that can emerge. And this is something that, along with Mu and Curry, we tried to discuss in a science paper a couple of years ago. As big data meets public health, we have opportunities for transforming the way that we react to public health dangers. But at the same time, we have to be very careful because many of us will be tempted to attack questions and problems and analysis that have a very low prior probability of having anything hidden within that haystack. So there may be just one needle, or maybe there's no needle in the haystack. And just getting significant results, no matter what the threshold of significance is, doesn't mean much. In some of the databases that I have been using with colleagues from Sweden, where we have the entire population worth of data, we routinely get p-values of less than 10 to the minus 100. And most of the time, they just mean nothing. And one has to try to sort out which one of those means something. So how about randomized trials and hybrid designs? Along with Hans-Olof Adami, a number of years ago, we proposed that maybe we can marry epidemiology with randomized trials, and we can nest randomized trials within large cohorts and biobanks and try to study lifestyle interventions, actually multiple such lifestyle interventions within the same data set. And if you have multiple interventions, you can also think of factorial design. So we call that a MultiLife design. Are there no randomized trials done for lifestyle interventions and for other prevention related interventions? Actually, there are. However, they're typically non-regulated. They're not like drugs. And they're pretty much fragmented. Along with Rafael Del Rey and Mike Bracken, last year we published this analysis of the entire clinicaltrials.gov database to try to see what's happening in that space. And there's a lot of action out there. We found more than 7,000 registered interventional trials of behavior interventions, more than 4,000 trials of diet or nutrition, close to 3,000 trials of exercise. You have some others that are not prevention. I mean, surgical interventions are not preventive. Well, sometimes they might. I mean, if you remove some organ, you will not get cancer in that organ. But other than very, very specific indications like high risk because of BRCA1, this has not been adopted for good reason. So there's lots of action, but actually most of these studies are pretty small. They're not registered, so what you see is just the tip of the iceberg. Probably more than 60-70% of the trials done in that era are not registered. Their outcomes are usually not very well specified. Most of the time they look at outcomes that nobody cares. They're surrogates that some laboratory marker went off, but why should I worry about it. Most of the time we have no good evidence of surrogacy. So we need some transformative change in that field. And perhaps we can think of moving towards large trials that we can randomize large-scale interventions in simple trials, maybe multiple such. This is just a list of things that citizens might worry about, what to do with their diet, with their leisure, with their communication, with their exercise, their mobility, transportation, their personal grooming, their sleep, their health care, but also other dimensions that go even beyond that affect their daily lives and how they live and how they survive. I would argue that we need to attract attention from the community about what it means to live well and to live a better life. And that includes health literacy, which is important, but I think it affects also other aspects of literacy like civic literacy, transportation literacy, technological literacy, finance literacy, and food literacy, all of which may affect each other and may also eventually affect disease and health outcomes. But even more than that, it would affect the everyday life that we are living. This is a busy slide that is trying to compare the MultiLife designs against randomized trials and traditional epidemiological studies. Each one of these designs has pros and cons, and I'm not saying that any of them is perfect and we can do with just one of them alone, but I want to discuss just a few features about what might be really essential in changing the paradigm and accruing some more reliable evidence. One major issue is compliance and adherence. Many of the epidemiological studies, both those that are uncontrolled surveys and those that are controlled, but also randomized trials when you try to go beyond a short-term follow-up, you run into the problem of compliance and adherence. People don't want to stick with the program. People don't want to come back for follow-up. I think it's likely that they will be more accustomed to the experience and may stay with us if we have pragmatic designs, if the trials do not really disrupt their lives, if it's part of their everyday life and they don't necessarily have to come for 10 clinic visits to measure some information. Maybe they can do things online. Maybe they feel that they participate in the research and they're part of it. Maybe they feel that they even co-design the research. So we need to find ways to motivate people to feel that they're not participants, but they are it. They are doing that for their community and for themselves. This is not going to be perfect, though, so there's always going to be some selection bias. It's likely that we will attract the most motivated people, and it's also likely that there will be some selection bias that will deviate from full real-life experience. A second concern is how to balance false negatives versus false positives. False negatives are, I think, not a major concern, especially if you go for very large studies, except if non-participation and attrition were to decrease the sample size to something that is entirely different than the original intention. Also, if the effects are so small, then I would say that that's fine. Let me miss some. I wouldn't worry that much. False positives may still occur due to chance, but one may replicate effects across different cohorts and different biobanks, and if there's consistency, then that makes a stronger case. And if these come from experimental studies, I would say these are experimental studies done in several cohorts and nested in several cohorts, and we get the same results. That's really nice. And also selective reporting biases should be less of a concern if we have a transparent biobank and cohort rather than the average randomized trial that is very easy to disappear. So it's run somewhere and then nobody publishes because they don't have time, doesn't seem to have very interesting or significant results. How about what outcomes to select? I would argue that we need to select, again, pragmatic wellness outcomes that matter to people. And as a first step, we need to go out there and ask our citizens what does really matter to them. Of course, death does matter, but I hope that I will have to deal with that maybe, who knows, 30, 40 years down the road, unless I'm stressed out from the discussion and I have a stroke. But what would matter for me now? What is important for me for living a better life? What does wellness mean to me? And for disease outcomes, we can link to registries. So we can see what happened 30 years down the road or 40 years down the road. When I'm dead, you will publish my results and you will acknowledge my contribution. Trial cost. Trials can be expensive. From experience that we have for drug trials, a data-intensive trial of 10,000 randomized participants may cost $210 million for a follow-up of 4 years. So if you want to do that for 500 lifestyle interventions, that's completely impossible. But we don't need to spend that much. We can simplify data collection, and there's evidence even from drug trials that you can bring the cost down by over 90%, and you can allow multiple studies to be run with the same cost or even less. Having a cohort and a registry in place that you can embed these randomizations may dramatically decrease the cost further. I would argue that we can perform randomizations for practically no cost. Is that a utopia? No. Google does that every day. Probably they do, I don't know, maybe 1,000 trials every month to understand how people respond to different types of stimuli. Eventually, we need to engage our community. We need to forget about people being subjects or participants and think of them as citizen scientists that share with us their concerns about what is important for their wellness, for preventing adverse events that they don't want to see happen to them or to their family or to their community. And wellness is not the opposite of disease. It's not even the same as health. The example that I discussed in the JAMA paper that I showed you a snapshot just now is that a dying patient may have perfect wellness. Maybe he's surrounded by friends and family and has no pain, and he feels fulfilled about his life, feels that he had a wonderful experience and everything that he wanted to do was done. And his wellness score may be 100 out of 100, while his health score is 0 out of 100. A healthy person may also have low wellness. So I may be perfectly healthy, physically and mentally, not crazy, but maybe I feel that I'm not creative enough, I'm not materializing myself, I'm not doing the things that I want to do with my life. So health and wellness are complementary, and I would argue that preventive medicine may need to shift more of its attention towards wellness. This is exactly what we try to do at Stanford with our next generation project. We call it the Wellness Living Laboratory, or WELL. We're trying to define or redefine what wellness is, and we want to include, actually, our sample of people who we have asked want us to include not only things like diet and exercise and physical vitality, but also mental alacrity, social well-being, personal fulfillment, creativity. How do you feel about yourself, about your work, about your security, your financial situation, and so forth. So that would switch the emphasis in health-oriented research to wellness outcomes rather than just health outcomes or absence of disease outcomes. And currently our effort is being launched in 3 sites with 10,000 people recruited in each as the first wave of enrollment. So 10,000 citizen scientists in each. We're starting in California, in Guangzhou, and in Taipei. And based on some discussions that I've had in the last few days, I think that there's a good chance, or maybe even certainty, that we would start in Singapore as well, which I really hope that will materialize. And we really want to expand that effort more broadly. What we envision is an online registry or a next generation cohort that citizen scientists contribute information related both to a core wellness module, but also additional details and add-on modules, and some modules that they may shape because things are important for them and they feel that they're important for their lives. That information may be integrated also with other linked databases that are available. And we can also have the opportunity to test multiple randomizations on these citizen scientists. They may opt to choose to participate in 5, 10, 20 out of 500 randomizations that may be available to them. If you have a biobank in place, which is the plan to have, you can also link these randomized trials to biomarkers and try to see whether you can also have biomarkers of both correlates of wellness, but also wellness response to different interventions. I will stop here and thank you for your patience and open for discussion and questions. Thank you.
Thank you, Professor Ioannidis, for providing lots of food for thought, I think quite in the literal sense as well. And I think a lot of us will now have a lot of ideas that we're willing to unleash on the rest of the audience today. And so for this segment, which is customary for our dialogue, which is the panel dialogue, I would like to next welcome Professor Lee Hin Peng, the moderator of the discussion on stage. Many of us here are familiar with Professor Lee, who is a public health veteran here in Singapore, especially in the areas of epidemiology, cancer and chronic diseases research, and also he was my former hallmaster when I was an undergraduate here. He has spent many years at the school, formerly as head of the Department of Community, Occupational and Family Medicine from 1987 to 2001, and currently heads the Leadership Institute for Global Health Transformation, also known as LIGHT, here at the school. Professor Lee, please.
Thank you, Alex. It's my pleasure now to invite the panelists to come forward. First of all, Professor James Best, endocrinologist, and who is now the Dean of the Lee Kong Chian School of Medicine in Singapore. You came in 2014, about 2 years ago. Yeah, so trained endocrinologist, and of course with this very special interest in diabetes mellitus and diabetic care, right? So thank you for joining us. Next we have Dr. Derek Heng. Dr. Derek Heng is the Group Director of Public Health at the Ministry of Health, and he of course looks after everything in public health in the ministry. So trained in internal medicine and also epidemiology, and he's involved very much in public health policy development with regard to control of both communicable and non-communicable diseases. Last but not least, Professor Rob Van Dam is a nutritional epidemiologist, trained in Holland and Harvard, Boston, and he's now in the school here as associate professor as well as the domain leader in epidemiology. And so he, of course, has a very strong interest in not just looking at the etiologic factors, but also to do various studies on behaviors related to dietary selections and choices, and the population interventions in control of obesity, type 2 diabetes, and so on. So thank you, Rob. Well, I'd just like to start this session by requesting our panelists to give us comments, about 5 minutes each. Professor Best.
Thank you. Well, lots of food for thought, as was said in the presentation. There are a few issues that particularly interest me. I guess the issue of prevention of diabetes, which is extremely topical, and linked with that cardiovascular disease and cancer, comes down to two areas of lifestyle, in particular nutrition and physical activity. But there is a third dimension to which Professor Ioannidis referred, and I guess that is the psychological well-being or degree of happiness, and I think in particular the idea of fulfillment. I think it's very difficult to link directly a feeling of happiness, fulfillment, or lack of stress in one's life with poor health outcomes, but there's so much anecdotal evidence about people who become ill, or the mortality that's associated with retirement, with loss of a partner or a spouse, also the positive aspects of having a pet, for example, or being socially connected, and the link of social isolation with illness and mortality. And I think the concept of that occurs in standard trials, of trying to pick out one individual element out of all of those aspects, out of physical activity, out of one's dietary habits, and out of one's social and work life, is really a crazy concept. Because if those other metabolic factors are interconnected, as you demonstrated, well, surely all of those other aspects are interconnected. And so studying a package rather than trying to break it down into individual elements, and then intervening as a package rather than trying to pick one individual element, for example carrots, and so doing a huge study to see whether eating more carrots is going to make a difference. Incredibly expensive and practically useless, I think, as you demonstrated. I guess the final point I'll make, because I think my 5 minutes must almost be up, is, you know, how do we create change? How do we change our own physical activity? How do we change our own nutrition? And how do we change our feelings about life, our social connectivity? It's all about behavioural change and the balance between what's the role of government in this. Does government have a responsibility to nudge us in the right direction? There are a number of levers that government can use. And what's the level of, in a free society, of individual responsibility to make those changes, and how do we help individuals to make those positive changes and improve their health? I think that's a point for discussion and a challenge for both government, not necessarily just Ministry of Health. I think it's a whole of government responsibility, but also giving individuals the tools that they need to take their own responsibility for their own well-being and their wellness, their happiness.
Thank you, James. Well, you've asked for a response from the government. There's a government official there. So, Derek, yes, please, yeah, you can take the mic.
Yeah, of course, the first thing I have to say, of course, is that nothing I say represents the views of the government. And my views are purely my personal views. But anyway, I think it's a pleasure to be invited as a panelist. My interest in public health actually first began with an interest in clinical epidemiology, so I think it's happy to hear John's talk about the latest developments in this field. I haven't been keeping track lately, so when I studied, the latest thing on the blog was nested case control studies. Now I have on nested randomized control trials. So interesting developments indeed. I think the perspective I would like to give perhaps is more from continuing from what Professor Berg has mentioned, to say that we actually may want to look at systems level, environmental level changes, like to try and nudge or encourage behavioral change. And sometimes the issue at hand is not what to do, because controversies aside, we largely know what to do. Physical activity is good, be more active, eat more fruits and vegetables, very uncontroversial. Of course, the more controversial stuff is like, whether fat fats or fats are good for you, whether high calorie diet. But anyway, but the issue basically, most of the time, after digesting all the epidemiological findings, we do know what to do. The question is that, but people don't do it. And so how do we examine interventions to encourage behavioral change? And I suppose the question basically is, how can a nested RCT do this? And because your engaged citizens or citizen scientists could probably do it at the individual level, so they could actually be randomized into doing something or not doing something. But how do you randomize into environmental changes, which are often at the programmatic level that encourage certain types of behavior, which is something that governments are interested in it because it is something that governments can do to influence. We don't have thought control, right? So we can't control thinking, but we can control the environment, including policy environments, physical environments, including nurturing social environments as well. So that's something that we want to think about. So related to that, of course, is I think the role of program evaluation. So how do we capture the value of prevention, right? When we already have program level interventions that are being rolled out, or when you want to test program level interventions rather than individual level interventions. So those are some things that very interesting to discuss. I think the other interesting methodological issues mentioned to me would be, I think, in terms of the correlation group. The question is that whether correlation group basically is just an analysis of how much confounding there is out there. And I totally agree with John's sort of statement that actually often you need a very strong prior, because if your prior is weak, and even if you have a strong p-value, I think it's actually you're finding nonsense or something that's really randomly correlated with what you're studying. Yeah, I think so. That's I suppose the other point to make as well is that for randomized, for RCT, netted RCT design, I think we would have decreased representativeness because often this would be the very engaged ones who are willing to experiment so-called on themselves. And the question that I have would be, I think, whether what we're finding to come up with, whether there will be concerns about effect modification. Then essentially the findings apply to motivated individuals, but they may not necessarily apply to unmotivated individuals. But those are some things. Yeah.
Thank you, Derek. Rob, you would like to carry on?
A couple of comments. So, first of all, I will have to address your comments about the cookbook approach, because as a nutrition ethnologist, I feel a bit defensive about this. I think you'll probably not be surprised when I say article, most research findings are false, and in nutrition we'll go for that. It seems like an over-optimistic interpretation that suggests that a big chunk of the finding is true. I think we have a variety of cancer outcomes, a variety of level of intakes, a variety of study designs, including retrospective case control studies, which are not so suitable for dietary studies, small studies. Not so surprised by that finding. Fortunately, what I'm seeing is in the field, things are moving forward. There's big, large-scale prospective cohort studies. There are pooled analysis as part of EPIC, as part of Pudding Project of Diet and Cancer, as part of the FORCE Consortium on Biomarkers and Cardiovascular Disease. So there's a movement towards larger studies that look at consistent results. But a tricky part of it is that even once you have consistent results from observational studies or cohort studies, how do you get to the truth? Even then, how do you know that it's real? Because there's also a big problem with the randomized control trials. We alluded to, you can do randomized control trials of single components of the diet in capsules, and that's been done quite frequently, vitamin E, not even carrots, but only beta-carotene. And that may not be the way to go, that has not been successful. On the other hand, there have been trials of full diets, like the low-fat diet in the Women's Health Initiative. And what happens is that with a lot of effort, with enormously dedicated staff, they succeed in people changing their diet for a year or 2 years, but then, of course, the intervention group and the control group, they all converge towards a normal American diet, so you don't see that contrast anymore. The same with the Mediterranean diet and the Predimed. The control group refused to eat a low-fat American diet, they just went back to the Mediterranean diet. And I can understand that. So that's the tricky part. So even if how do you get to the truth in nutrition? Even if you have a consistent observational evidence, how do you take it forward? So if you do randomized control trials of asking people to eat more nuts, they will be confounding because the people who are successful at that, eating nuts, although they may not even like it that much, are different people than people who don't succeed at that. They may be more disciplined, they may be more health conscious. There's a lot of issues with that. So it's another type of confounding, but still confounding. What does seems to work if you give people nuts every week, then people start eating more nuts, like in fatty medicine. So how do we get to this truth? I think that's the big question. Because I agree, if we talk about prevention, we know a lot about prevention. We know that physical activity is beneficial for diabetes, for heart disease, for stroke. Not smoking is tremendously beneficial. Excessive alcohol intake is an obvious thing to avoid. But when it comes to diet, we know some things, but we don't know a lot. Yeah? We don't know, really, is red meat that detrimental? Are eggs very bad for you, or they're not so bad for you? What type of fruit or vegetables to eat? So diet is really an area where we also need a stronger evidence base before we can really recommend people firmly what type of specific diet recommendations to take, because we've been asking people to take a low-fat diet for decades. Some people have taken a low-fat diet for decades, which may not have improved their wellness, but certainly it hasn't improved their health in terms of chronic disease outcomes. So there's some issues out there when it comes to nutrition recommendation, and getting to the right evidence. I would like to end on a positive note though. There are some positive findings, for example, folic acid, prevention of neural tube defects, are consistent for observational studies, also very successful for trials. Now recommending all the women to use folate during pregnancy. In terms of polyunsaturated fat and trans fat, there's still some controversy, but it seems that at least the short-term trials, some of the long-term trials, and the observational evidence seems to coincide. It gives some basis for prevention. More recently, what has been quite exciting is lifestyle prevention on diet and exercise and diabetes prevention. The observational evidence suggests that most diabetes can be prevented through lifestyle changes, and the trials show the same thing. So that's been very reassuring. When it comes to Mediterranean diets and CBD, there's some evidence out there from the Lyon Diet Heart study, from the PREDIMED study, and from a wide range of observational evidence from across the world that is indeed a beneficial diet. Medium fat diet with lots of fruits and vegetables, whole grain and nuts and legumes. So I think there's also some positive news, although I do agree fully that most, if not the great majority of research findings in nutrition and health will turn out to be false. Thank you.
Thank you. John, you want to respond to some of these comments very quickly, and then we will have time for some questions from the audience.
Great comments. Very quickly translates to 30 seconds or 3 minutes or 5 minutes. So it's hard to prioritize because there were so many great ideas being proposed. Let me try to go in the same order. So clearly we need to agree on what is important for us. So illness and mortality is very important. But I think that many of the prevention efforts and many of the wellness definition and redefinition may not necessarily aim at curtailing the burden of traditional illness and mortality. I think that there's these other aspects of our lives that are still less tangible that are very important on their own. So I think even if they don't extend survival, even if traditional disease definitions, incidence prevalence doesn't change, still if they make for a better life, I think that they're worth trying to study and measure and affect and ask people what really makes their life better. How much can governments do? Clearly a lot. I think that Singapore in particular has been a very nice paradigm where the government has heavily invested in transforming the lives of people in education, in health, in many other aspects, in very effective ways. The question is how much feedback do you need that different interventions really work, because there are lots of very nice ideas, but not necessarily all of these nice ideas pan out, and not necessarily all of the indices that you may want to capture will be equally important, so that there will be some indices that are very informative and others that may have no information at all and may just be generating tons of information that is complete waste and maybe sometimes even misleading, because then we just try to fix the index and we kill the people, we make people unhappy and the index flourishes. In terms of successes and non-successes, I think we're very much in the same wavelength with Rob. The trials that got negative results repeatedly on different nutritional interventions, I wouldn't call them non-successful, I would call them very successful. I think that they were very informative. So success does not equate with significant results. I'm very happy to see non-significant results. I'm biased in favor of non-significant results, obviously. And a couple of weeks ago, I published an editorial in the American Journal of Clinical Nutrition arguing that we need more large long-term trials, preferably with negative results. Because we just have so many ideas and so many possibilities to pursue that it's important to get rid of 80, 90, 95, 99% of them so that we can focus on that 1% that is likely to be most useful. There are some successes that we've managed to identify with current designs. Yes, there are not that many, and I think that there's a vast space that we're still missing, because I do believe that diet is important, but somehow we have depended on study designs that are not telling us what exactly is important about diet. I would argue that randomized trials is the way to go. I don't worry that much if people converge in their dietary experiences after being randomized within, let's say, 6 months or 1 year. If this is what they do, then we know that that's not an intervention to follow. I don't really care that much if biochemistry and biology says that this ingredient or this diet is really great. If people cannot take it, you know, that's good for robots or for animals, but it's not good for humans. So I'm interested in humans, and I'm more interested in finding ways to implement interventions that people can take and not just tolerate, but love for years, for 10 years, for their entire life, rather than very effective biological interventions that no one can take more than a few months. Because eventually their benefit of the latter case is going to be very limited. So I think we can continue using different designs, but I would argue that more randomized, more experimental evidence and more real-life evidence is what we need to make some sound decisions.
I think you keep the mic because you're good. Questions? Anybody? Just use the mics by the aisle, and you can, just give us your name and then shoot questions or comments. Anybody? Yep.
Thanks, Vic. Park Hai-Hong from the Lee Kuan Yew School of Public Policy. I used to be here in the medical school, and the school was still in the department. So it's nice to be returned to my first love, or rather one of my loves. Before that, in the Ministry of Health, which was a love-hate relationship. Anyway, well, thank you, John, for that nice talk to catch up with some of the latest. But I was a little disturbed with your comments about how some of the recent trials have not been validated. Now that poses a lot of problems for policymakers, the Ministry of Health, because how then do you implement the science to go from the evidence to the policy when the scientists keep on changing? A few mentioned about hormone-based mortality, and then the latest now low-fat diets and cholesterol. I think that's disturbing. So when we are putting some value in the prevention, the scientists must come to a consensus first, right, based on the evidence. Then you can translate it into policy. Otherwise, the value in terms of its cost effectiveness will be lost. So I'm just wondering, from the value perspective now, when we implement what is quite obvious, there's a lot of it's not rocket science, there's a lot of things that needs to be implemented that's not implemented, and then we implement very specific things which are so controversial right now. And so there's a lot of slip between the cup and the lip right now. We know a lot of good science, but that's not translated into policy. And yet we get into a lot of controversies by emphasizing things which are a little out of context. So for example, emphasize certain parts of things which is cultural, which is highly contextual. Like, instead of say focusing on high-calorie diets and sugar with all sorts of other overconsumption, we focus on just rice. You know, so I think that's very controversial. Thank you.
Thank you, John.
I think that this is a very real concern, and I don't have a perfect answer to that. I think that policy ends up being a black or white decision, so we either do or not do something. But we still need to keep in the back of our mind the uncertainty that exists for each one of these black or white decisions. So we need to make the best choices that we can, and we will know that there's 5 things that we do with very high certainty and with very good evidence that they will have high yield. And there's another 20 things that we do because they seem to be pretty inexpensive, they seem to be easy to do, and even if they have a 10% chance of working, they might be very beneficial. But I think that we should be able to be both accurate, transparent, and honest to ourselves about what is the level of certainty for each one of these decisions that we're making. I'm happy to make decisions with 10% certainty or even less sometimes, but I want to keep in the back of my mind that let's be careful because maybe we are misleading ourselves and misleading the population, and we need to revisit that if more evidence becomes available.
James?
Perhaps we do overemphasize some of the areas where there's controversy because that's what's exciting in science. But I think as Rob said, there are a fair, and as you said, John, there are a fair few things we know. I mean, we know that having more fibre in the diet is beneficial, and that's linked with more fruit and vegetables, having a diet with plenty of fruit and vegetables. We do know that seeds and nuts and fish is, having fish in the diet is healthy. I think we also have a fair idea, enough evidence to say that certain foods are not healthy. That a diet that's high in saturated fat from red meat, for example, I think there's enough evidence to say that a lot of that's unhealthy, as you said before, or as I think maybe Rob said, excess alcohol is clearly unhealthy. And probably there's enough evidence because it leads to obesity at least, that diets high in refined carbohydrate, in sugar. The fructose-containing soft drinks, a high intake of those are not healthy. The evidence doesn't have to be absolute because little in life is absolute, but there's good enough evidence in those areas, and perhaps we should focus more on the positive emphasis, on the positive evidence rather than the controversial areas, which of course both scientists and make newspaper headlines as well.
No, I agree with that. I mean, we always like to stir up the controversy, say we don't agree on. That's the most exciting thing to discuss, of course, because I mean, we're not going to say for the 100th time that fruit and vegetables are good for you, or that whole grains are good, or nuts are good. It gets too boring, but of course it's more true. So we do reckon, yeah, it's like, physical activity is good, but should be like resistance training, should be aerobic training. We always try to find the controversy in these things as scientists. So I think there's a lot of common ground to build on in terms of interventions. And then it's not always only telling people to do what they do, it's also facilitating that people even have the choice to have a healthy life. So Americans going back to American diet may not always be because they think that's the tastiest diet in the world, but also because everybody around them is eating that, it's cheap to go to McDonald's, and they don't have much time to prepare more complex foods. At least that's not their priority. So I think it's also like the recent developments that people can have unsaturated fats if they go to the Harvard Center. They can find whole grains on a lot of locations. It's not too expensive for people with a lower income. I think for the government to facilitate these choices, that if people want to do the healthy thing, it's also encouraged and easy. I think that's a key element.
Okay. Any other questions? Anybody would like to? Yes, please. Please use the mic. Give us your name.
Hi, my name is Shafali. I am a former healthcare reporter and a communicator. So I'm very interested in what you said about the difference between health and wellness, and also how the media tends to skew reports about the two. So I mean, you just mentioned we go for the fancy headline, we go for the dramatics. But how important are communication frameworks when it comes to encouraging wellness in communities and health as something that is owned by a community? And are there any studies around communications and how integral it is to health promotion?
Clearly, health communication is a very essential aspect of health promotion, and I think that there's many studies that have tried to assess different means of communication. Which ones are most effective? This is kind of a changing landscape, because it also depends on what kind of venues people go to seek communication. So you have traditional newspapers, but you also have social media, you have other types of communities being organized and interest groups, and I think that we need to be able to capture that changing landscape and to be able to intervene in a way that we will capture the attention and also the imagination of more people. Clearly, communication can be harmful. I mean, we know there's many studies that have shown that evidence can be further distorted when being communicated, because there's a natural tendency to exaggerate. There's competition in news, so people want to hear the most extreme news possible. So a small risk ratio is not very exciting, and as a result, it will disappear and it will appear as this is killing you, or this is what you're going to die of, or do this and you will live forever. I'm exaggerating, of course, but you see what I mean. And there's also empirical evidence that shows that Matthias Senger has published a study with BMJ a number of years ago showing that observational studies, the ones that I showed you that have such a low success rate, using success in a different way here, attract more attention than randomized trials. And the ones that have more spectacular results attract even more attention in the news. So I see two functions. One is news being able to inform the public in a more balanced way, and probably remove the need for extreme results when they're communicating information about health. Just try to be objective and balanced and offer accurate information. And second, try to use that machinery to communicate the best interventions, the best things that people can do with their life, that they can try out and see if it works for them. Because you have tremendous power. You have more power than 100 professors combined.
Yeah, I think one aspect of it is that the news media will, of course, cover news, that new findings, new exciting developments. But there should also be resources where people can find reliable, up-to-date, evidence-based information about diet and health, about other lifestyle factors. So even if they're confused about what's in the news, they can go back to that. So it could be the Promotion Board website, or we started the Asian Diabetes Prevention Initiative website, or other websites like the Harvard School of Public Health Nutrition Source website is very popular. So people have some kind of resource where they can go to and kind of get the totality of the evidence reflected. I think that's also very, very useful.
Derek, yes.
So indeed, I think the issue basically is that what does the public view as trusted sources of truth, and whether there's a need to develop sort of trusted sources when there are exaggerations out there. And I think, as John mentioned, essentially the landscape is such that the more outrageous the claim, the higher the news value, and the higher the publicity value. So I think the question is that what the School of Public Health what can they do? What do they see as their roles to actually serve as arbiters or serve as moderators, right, of some of these results, to say that hang on, yeah, sure, that's just one study, and so on. Yeah.
Another question? I see two hands. The lady in red, please. I'm sorry, I don't know your name.
Thank you very much. Good afternoon, I'm Jessica from KDPH. I'm a practicing pharmacist from KDPH. So I'd like to actually address this question to Professor John and to everyone on the panel. So the thing is, when I just saw today's talk, it was on capturing the value of prevention. And a day-to-day work of a pharmacist, actually, if you ask me, a lot of times we are doing prevention, preventing med errors, preventing the wrong dose or wrong medicines from being administered to the patient. So I would just like to ask for any practical advice, if there's any way to actually quantify this kind of interventions or cost savings. Yeah, because you know, at the end of the day, drug-related problems, etc., all these are very, very rare events. So how do we actually attach a price to that value of intervention?
Interesting question. I have to say that was completely off my radar screen, but it's one type of prevention, reducing errors in prescriptions or medical errors. There are a number of studies. There are randomized trials for some types of interventions. There's even some systematic reviews. I have published 2 of them with my team, one on medical errors. That includes the aspect of prescription component and management at the pharmacy level or at other levels of prescription, and also in diagnostic errors in the Annals of Internal Medicine a couple of years ago. So there are some interventions that have been tested and seem to have some effectiveness in reducing some of the errors being made. And probably take some time to expound on those, but there is literature, and probably there's also room for more studies to be done in that area.
I had a comment, perhaps not a direct answer to your question, but I was walking through a hospital this morning, I won't say which one, and there was a huge advertisement up on half the wall for a vitamin called Centrum that was supposed to prevent heart disease, a special formulation to prevent heart disease. Well, I think I can safely say that there is absolutely not a skerrick of evidence that taking that vitamin would do anything to prevent heart disease. And you know, from some of the studies using vitamins to prevent cancer, they actually, particularly in smokers, they actually caused more cancer. So who knows, whether that's harmful or not. And I think that it's really important for all of us to try and prevent people using surrogates for healthy behaviour, thinking that taking a multivitamin tablet is a substitute for a healthy diet or for a good level of physical activity. And I think, all of the health professions, particularly pharmacists, need to work together there. Now, I sort of hesitate to move from there into the realm of traditional Chinese medicine. But what I could say is at least there are sort of centuries of practice and anecdotal evidence there, and I think that's quite a different type of, that's a very different approach. And there's a lot that goes along with the use of traditional Chinese medicine compared with popping vitamin pills.
So maybe just a comment to say that I think in terms of answering the question about how do you capture the value of pharmacists, I think the problem, of course, is that if you already have a pharmacist service, it would be unethical to withdraw the service, right? Because but what you actually want to know is what would have happened if there were no pharmacists there. So therefore it's challenging to do that study. Now what you can probably do is to look at the number of errors that you catch and try and extrapolate the consequences of those errors if you weren't there to catch them, essentially. The other thing that you could do, of course, if you were starting a new service, then it might be ethical to randomize, to see that actually some patients go to the new service, some patients don't, and then you can actually probably much better demonstrate value of the new service.
Thank you. We'll have last 2 questions. Yes, Mary. Yeah. And then the last one at the back. Yeah.
Hi there, it's Mary Chong from School of Public Health. I'm a dietitian by training and a nutrition scientist. I've got a rather ignorant but potentially provocative question, stroke comment. So I like the whole idea of this holistic approach instead of looking at individual nutrients. However, coming from a potential, citizen scientist point of view, I like the whole idea of this wellness program. I mean, I get very excited because it seems as if I'm going to get my own personal dietitian, personal physiotherapist, personal psychologist, etc. to help me with lifestyle change. But I also get very stressed because it means, wow, how many changes do you want me to make in my life? So I guess the message I'm trying to get is, even from a scientist as well, it's easy to target very individual kind of nutrients or food and then sell the message than trying to push for a holistic package. And then where do you attribute the benefit to? So I guess the question to you is how easy is it to kind of sell a package of things compared to kind of simplified messages where people can then adopt and also target in terms of policy changes? Yeah.
It's a very interesting question and a pretty complex one because I think that the packaging of messages and of intervention is something that is not very well studied. What we know is that once you leave the design where you have very, very simple interventions, you can very quickly get into a situation where there's so many aspects in the way that package is implemented that it's very difficult to identify which of the multiple steps or the multiple pieces are the most essential ones. And it could be that some of these pieces are more essential for some people and others are for some others. So recently we're writing a paper describing the design of a randomized trial on nutrition that we have been running at Stanford. And it took us about 1,200 words to describe the intervention. But if you want to be accurate, you really need to say exactly how this is being done. So increasingly we're moving towards describing package interventions. But we have to be very careful about describing what that package is so that others could potentially implement it in the future. Paul Glasziou has done some very nice research looking at whether interventions for randomized trials are described accurately, and he has shown that the majority are not described in published papers in a way that someone reading that paper could take that intervention and use it. And that includes things like drugs, which supposedly should be, this is a drug, this is the dose, and this is when you need to give it, and it's IV or IM. When it comes to things like a diet, or even more than that, a package that includes compassion and psychology and diet and how you feel about yourself and your children and your parents and your ancestors, it can get very complicated. So we have to be precise. We need scientific precision like in anything else.
Okay, thank you. I think the last question, yes.
Thank you very much. Tilo Hagen from Biochemistry Department. I want to come back to the role of the government, which has been raised a couple of times. So the Singapore government has done a lot in terms of education and also in terms of encouraging people to do physical activity. But what about the legislation aspect, right? So I haven't actually seen much activity in that area apart from the tobacco and the alcohol tax. But of course, it's very good for. We all know that eating nuts and berries and having salad for lunch, is very good, but it's a lot more expensive. And I think for the general public, the one major reason for not having a healthy diet is the cost, right? So I was wondering, whether the government is thinking about taking more steps into this direction, because in the US, of course, there has been more activity in this area, and whether the other panelists think the governments should do, or because it also affects, the freedom of choice and all this. Thank you.
Derek, you have a comment?
I think the short answer basically is that we are basically very evidence-based, so we'll consider interventions that work or have been shown to work, whatever the interventions are. Right, but I think there is more scope, right, for legislation in looking at things that are bad, such as alcohol, such as tobacco, right, than in promoting things that are good. I mean, you can't legislate that you must take fruits and vegetables every day, for example. But having said that, I think there are probably other ways in which we can try and change the policy environment. We can try and change the social environment. And I think we are certainly open to ideas on how best to do that.
Okay, thank you. I think That's all the time we have this afternoon. At the end of this session, you're most welcome to a reception downstairs, level 2. I can't guarantee you that the food is healthy. So that's another point. It's better to walk. It's only one floor. Don't take the elevator. So that leads me then to request you to thank Professor John Ioannidis and the panel. Thank you.
Professor Lee, thank you for inviting the thanks to the panel members. Also a very warm thanks to the members of our audience for taking the time this afternoon to join us. I'm sure the session has really sparked some ideas for all of you. I've written down here that a quotable quote to hang over the mirror in the morning is, "Success is not assured by having a statistically significant result only." And I think that's something that us as young researchers, we should take home. But now, before we wrap up the session, I would like to call on our school's dean, Professor Chia Ki-seng, to come up on stage one more time and present a token of appreciation to our panelists, Professor James Best, Dr. Derek Heng, and Associate Professor Rob Van Dam. Okay, lastly, before we unleash you onto the buffet spread, we have a very special token of appreciation for our guest speaker, Professor John Ioannidis. As is customary for the School of Public Health, it merits an explanation, so I'll hand the floor to Prof. Chia.
Well, I first met John, I told you, about 10 years ago, and that was at Karolinska Institute. And at that time also, as I mentioned earlier also, that one of his most famous publication was this paper, Why Most Published Research Findings Are False. But at that particular symposium, we were just over tea talking about research and so forth, and all these ideas that he had been sharing with you this afternoon. He came up with this idea, why don't we write a paper together? And comparing genetic variables and non-genetic variables to see how different they are, and he came up with this idea of having this correlation globe. So of course I said yes, to publish together with someone who's having the most cited paper, of course. Lo and behold, the next morning he gave me a draft of the paper. With the introduction, materials and methods, dummy tables, and how to construct this correlation globe, and so forth. And after a while, we published this paper in Science Translational Medicine. So we're thinking of how best to give him a token of appreciation. Instead of going to the shop and buy something, our colleagues from the ERO came up with this idea of, why don't we do this? And so now we have a customized or personalized poster that we'd like to give to John.
Thank you, Dean, Prof. Chia Ki-seng, and Professor John Ioannidis, as well as our panelists. That brings us to the conclusion of our Public Health Leadership Dialogue. And I think I would like to take this moment at the end of the session to remind you that we will be holding the second Singapore International Public Health Conference from the 29th to 30th of September this year. Now, for those of you who have had your research rekindled, like I said, you do not need to have a statistically significant p-value to be of merit to be heard. Do note that the submission deadline for abstracts has been extended to the 1st of June. So you have about 14 days, that's 2 weeks, to submit your abstract. I think in that time, judging by Prof. Chia's input, Professor John would be able to produce 14 abstracts in that time. So I think the rest of us could all produce one at the very least. I'll give it my best talking about interventions in the military. But thank you again, all of you, for coming today. Like we said earlier, there will be refreshments served at level 2. Do take care to take the staircase as you're going down. I think our ushers will lead the way. And once again, thank you very much for coming to this afternoon session, and hope to see you again soon. Goodbye.